little snippet of who you are and where you're coming from. I know I need to do our time, so everyone out. Just as a heads up, we do have chat function. You pay attention to it. So if you are having any issues or you want something to say and you can't get it in there, or your mic is giving you troubles or whatever, please feel free to use the chat function, and we will interact with you that way if other technology is failing you at the moment. We'll go ahead and get started with introductions. Bill Brooks, if you'll go ahead and unmute and introduce, please.
Hello, everyone. I'm Bill Brooks, assistant professor of biostatistics in the College of Public Health here at ETSU.
Great, thank you, Bill. He is the honor of sharing the presentation for today with the next person I'll ask to unmute and introduce, and that is Meredith.
Hi, I'm Meredith Ginley. I'm an assistant professor in the Department of Psychology at ETSU, and I'm a licensed clinical psychologist.
Great, thank you, Meredith. Tanya, her mic isn't working, but she's in the same room as Veronica. So I'll get those two together and they can introduce themselves.
Hi, I'm Tanya. I'm the medical assistant with the Addiction Medicine Fellowship here at ETSU.
And I am Veronica Van Ray, and I am the Certified Peer Recovery Specialist here at ETSU.
Awesome. Thank you guys so much. I love this teamwork in the same room, making it happen. Veronica's actually got our case presentation for today as well. Skylar, if you can unmute and introduce.
Hi, I'm Skylar Geller. I'm one of the Addiction Medicine Fellows at ETSU.
Fabulous. Thank you, Skylar. And the all-important Brian, our tech man, you can unmute.
Brian, I'm the technology coordinator for ETSU CME. If you have any technology issues, you can send me a chat, or my phone number is listed in the participants.
Great. Thank you, Brian. Jack, if you can unmute and introduce, please.
Hey everybody, I'm Jack Larson. I'm one of the second year residents over at ETSU Family Medicine.
Thank you so much, Jack, for joining us again. Cameron, if you can unmute and introduce.
Hi, my name is Cameron Hayel. I'm a psychiatrist, addictionologist, and associate professor in ETSU, associate program director in our family medicine, addiction medicine fellowship.
Fabulous. Thank you, Cameron. Noel, if you can unmute and introduce, please.
Hello, everyone. I'm Noel Diaz. I'm a third year psychiatry resident in Memphis.
Great. It's good to have you with us, Noel. Carrie Lynn, if you can unmute and introduce.
Hi, I'm Carrie Lynn Dally-McClay. I'm an assistant professor in the ETSU Gatton College of Pharmacy.
Beautiful. Thank you for being with us, Carrie Lynn. Jennifer, if you can unmute and introduce.
Hi, I'm Jennifer. I'm a fourth year pharmacy student, and I'm on an academia rotation with Dr. Dally-McClay this month.
Oh, beautiful. I love it when we have people who bring their students along. Thank you, Carrie Lynn, and it's good to have you with us, Jennifer. Brooke, if you can unmute and introduce, please.
Hey guys, I'm Brooke Claiborne. I am the behavioral health, substance use disorder, and my case manager and addiction grad student.
That's wonderful. Brooke has got her plate full of lots of exciting things. Thank you for being with us, Brooke. Michael, if you can unmute and introduce, please.
I'm Michael Mishka. I'm a psychologist and clinical director for behavioral health operations at 10 Care here in Nashville.
Beautiful. Thank you, Michael. Today, we've got East Tennessee, Middle Tennessee, and West Tennessee. We've got it across the state today. Good job, guys. Angela, if you can unmute and introduce.
Hi, my name's Angela. I'm an F&P resident with ETSU. So
Wonderful. It's good having you with us again, Angela. Katie, if you can unmute and introduce.
I am Katie Langley. I'm an ETSU psychiatric nurse practitioner in DMP program.
Beautiful. Thank you, Katie. Simona, if you can unmute and introduce, please.
Hi, everyone. My name is Simona. I'm one of the Addiction Medicine Fellows.
Great. Thank you, Simona. It's good to have you joining us. Chris Copeland, if you can unmute and introduce, please. Chris usually has on his camera, so he may have stepped away from his computer for a minute. Nope, there he is.
Hey, did you say my name?
I did, sir.
Sorry.
Okay.
Yeah, I'm having a new computer camera problem, so I can't get a video to come up. I'm Chris Copeland. I'm a addictionologist at Revita Recovery Newport office.
Great. It's good to have you with us, Chris. New computer woes, totally understood. I'm in the same boat, mister. It's not fun. Thank you for joining us. Judy, if you can unmute and introduce.
Hi, I'm Judy. I'm a psychiatric nurse practitioner resident with Angela, and I'm excited to be here.
We're excited to have you with us, Judy. Thank you for joining us again. And then I'm going to go ahead and introduce the Auto LTCNU42. That wonderful name on there is actually representing the Norton Community Hospital Residency Program up in Norton, Virginia. And there's about 10 residents in the room and a gathering of medical students as well joining them. So it's good to have the whole gang there represented by a single tile. Thank you guys for joining us again. I think this is at least the second time you've been with us, so I'm glad you found us again. Keith, if you can unmute and introduce, please.
Yeah, I'm Keith, Behavioral Health Case Manager with United Healthcare.
Wonderful. It's good to have you with us as well, Keith. And Sudha, if you can, yes, Sudha, if you can unmute and introduce, please.
Hi, I'm Sudha Kumar. I'm a nurse practitioner.
Wonderful. Thank you, Sudha. It's good to have you with us again. Can you hear us?
Yes, I think I can hear. It just got disconnected for a second.
Okay, good. Well, I'm glad we're reconnected. Excellent. I think we have gotten through all of our introductions unless there are any other announcements or anything that we need to say. Our coordinator isn't with us today. She had her second COVID shot yesterday, and today, as usual, after the second shot, yeah, you don't feel so hot. So I think the only thing that we have is, you guys have already seen it on the rotating slides, but I'll remind you at the end, we're getting together again on the 28th of April. That's 2 weeks from today, and we are looking for case presentations for the 28th and the 12th of May, so the next two upcoming. We have spots available. You guys are so lucky. You haven't presented yet. You've been waiting for your opportunity. We've got one in 2 weeks and another one in 4 weeks. So get your cases ready and bring them to us, okay? All right, with that, I'm going to turn it over to Meredith and Bill. Thank you guys for presenting today for us.
All right. So Dr. Ginley, I guess I'll just jump in and then, okay. All right, let me move my stuff around here so that I'm making eye contact while I'm looking at my slides. Very important. Minimize and share. That one. All right, can you guys see my title slide?
Looks good.
Excellent. Okay, so we split this presentation up. It's going to be short, so I'm going to try to be as short as possible to get to Dr. Ginley, who is an expert in a particular approach to managing stimulant use disorder. I'm going to give you a broad overview. I did want to read something real quick. I just got, there was an article that just hit the press from New York Times. You can't see my phone. Anyway, 11:52 today. About the overdose, the current state of overdoses. I'm just going to read this first paragraph because I think it's important. More than 87,000 Americans died of drug overdoses over the 12-month period that ended in September. That'd be September 2020. According to the preliminary federal data, eclipsing the toll from any year since the opioid epidemic began. The Prescription and Heroin Summit last week, and everyone is really sort of talking about this and the state of things with regard to overdoses. So if you didn't already know, everything that you're doing is very relevant. I mean, I apologize. I've got my email alerts are probably going to pop up. I think you guys can see that when it does that. Very popular, so that's a problem. All right. So Dr. Ginley and I have no financial conflicts of interest to disclose. We're going to talk about current trends in stimulant use, recognizing the importance of understanding stimulant use by individuals with OUD, and gain a more in-depth understanding of evidence-based treatment interventions for stimulant use disorder. All right. So trends in stimulant use. We're going to start broadly. When we're talking about stimulants, I just wanted to lay it out very clearly, sort of what we're talking about. We've got cocaine, methamphetamines, novel psychoactive substances, and prescription amphetamines. If I forgot anything, let me know. But the two that are sort of at play most dramatically currently are cocaine and methamphetamines, though I would argue novel psychoactive substances are the future of the illicit drug market and likely to be a real issue for a lot of reasons that I could go on and on about drug policy, the way FDA manages sort of approval for these different drugs, and the way the labs are kind of moving at a hyper pace to produce them to get around those regulations. So of course, cocaine is an organic substance. It's predominantly from Colombia, but comes from other countries as well. Methamphetamines are coming into the country through our southern border, being most produced at this point by Mexican drug cartels. We had a big domestic production of methamphetamine previously, but it has shifted, which has had a huge effect on the market itself with regard to potency and purity of the substance, which also has an impact on our overdoses and substance use disorders overall. I'll just say that my expertise and my interests are in the illicit drug market, and I will talk a lot about supply because it has a huge impact on what we're seeing and what we're dealing with in our patient populations. So I want to sort of lay that stuff out for you guys a little bit. And we can see here, surprisingly, because, honestly, we don't really talk a lot about cocaine. There's a lot of concern around methamphetamine and how, we're seeing new trends and its association with opioid use disorder and so forth. But cocaine is still very popular, very prevalent, and you can see sort of how the age groups break down there in the figure on the right. Perhaps most concerning, almost certainly most concerning when we talk about stimulant use is it's now concomitant use with opioids, specifically heroin and fentanyl as well. We're seeing, if you look, the figure on the right there, the top curve with the circle points there represents the almost tripling of reported use. I'm sorry, these are past month use in conjunction with heroin. And so any of you that are working in treatment currently, that this is the case, that folks are in for treatment. They're testing for methamphetamines in their urine and otherwise reporting use. And so this is a dramatic trend, and it has changed. And again, I would point back to the shifts in the illicit drug market itself on the supply side that have also kind of generated a real demand for these things. And we have seen historically kind of this cycle of stimulants and then opioids and stimulants and depressants and opioids, sort of the cycle over the last 120 years. This could be, the prevalence of this stuff along with opioids, given that there's a fair amount of methamphetamines in the supply that it's easier to get a hold of sometimes, and may help to cut the sharp edges off of withdrawals in between doses of your preferred opioid. This, of course, has led to a dramatic increase in stimulant-involved overdoses. So between 2013 and 2019, we saw this 317% increase in involvement. And honing in specifically to the 12-month period between June 2019 and June 2020, with that 6 months of, well into the pandemic, there's CDC reporting out on cocaine-involved mortality up 26%, methamphetamine-involved mortality up 34%. And most of this is likely due to co-use of synthetic opioids, specifically fentanyl, or adulteration of these substances. So fentanyl is being used to as a cutting agent for any illicit substance that it can visually mimic, which includes cocaine and methamphetamine and powdered heroin. I was, and they're finding that seizures of methamphetamine and fentanyl at the southern border are up dramatically over the last year, with fentanyl estimates up to 70% increase in seizures of fentanyl coming across the border. As I said, the novel psychoactive substances being the future of the illicit drug market, it doesn't require land and labor to grow any of the components of fentanyl. It can be produced in a lab, which is very attractive to any of the international drug organizations. And with methamphetamine, again, same, a chemically formulated substance, very attractive to the cartels as well, which is why there's been that shift of production in Mexico. The purity is very high and the potency has increased quite a bit. And this is due to its now formulation in industrial labs rather than the domestic production, which was pretty ad hoc, shoddy approaches, backyard cooks, shake and bakes with people using 2 liters. And we still see some of that in Tennessee. In fact, Tennessee is a bit of a holdout on the domestic production of methamphetamine. If you look at the 2020 National Drug Threat Assessment, there's some figures in there that lay out kind of where we're seeing still some domestic production of methamphetamine. So this supposed role of fentanyl or other synthetic opioids in overdose mortality associated with stimulant use is really highlighted here in these 2 figures. So if you look at the figure on the left, we have deaths per 100,000 with co-involvement of synthetic opioids. And you can see as cocaine and stimulants, the psychostimulants, including methamphetamine, increasing dramatically. And that all of those involve some form of synthetic opioid other than morphine. And then we move over to the right and we take out that involvement and looking strictly at the stimulant involvement, and we can see that our psychostimulants, including methamphetamine, are continuing to rise, but our cocaine mortality sort of flattens out. So you can really see the contribution of the synthetic opioids and the mortality there. And also, if you're still seeing that rise in the psychostimulants, that's likely due to the high potency of those substances produced in Mexico. So with stimulant use disorder, we have seen treatment admissions going up year over year, 27% increase between 2015 and 2017. But I think probably most important for those of us on the call here, and I think for my money as well, just in thinking of its effects on the physiology on a user's body when they ingest the 2 substances together, is we've seen this nearly 500% increase in reported meth use among individuals in opioid treatment between 2018 and 2017. We have seen, our overdose emergency department visits are more prevalent in rural areas. And anecdotally from, looking at things locally, we have spoken to folks that run or part of a methadone clinic here locally and have reported up to 95% of their clients testing positive for methamphetamine. And I think that's no surprise for any of the folks that are on this call. I know everyone that I have talked to working in treatment see these trends and are not surprised by the data at all. So yes, stimulant use has become a huge issue in the country. Of course, we've talked a lot about opioids over the last 20 years. And we are now we're considering the 4th wave of the overdose epidemic, starting with prescription analgesics into heroin, then synthetic opioids like fentanyl, and now our stimulant use disorder in conjunction with that fentanyl or synthetic opioid adulteration is what we're considering our 4th wave of the opioid or the overdose epidemic. So roughly 40% in 2018 of overdose deaths were attributed to stimulants. Tons of incarceration around this stuff, as well as a lot of healthcare costs as well. So we need to figure out, what our approaches are to treating this stuff. We don't have a lot of great options right now, but I'm going to stop right there. I'm going to let Dr. Ginley take over because she is the expert in those solutions.
Thanks, Bella. So kind of moving us from, okay, this is a problem to what do we do about this? And I think this has come up a lot on this call is what exactly are we supposed to be doing? So next slide, Bella, please. So contingency management is going to be a behavioral intervention that's going to be based on operant conditioning, where patients receive a specific reward or a point system or money, usually it's money, in response for engaging in specific behaviors. And contingency management's been shown to be the most effective treatment for stimulant use disorder, with the biggest effect size of any treatment, including cognitive behavioral therapy. And the interesting thing and important thing about contingency management is that there doesn't seem to be an income effect. It works for everybody. There's not an impact of contingency management being better or worse, depending on a person's race or ethnicity. And contingency management seems to work particularly well even with persons who have had multiple treatment readmissions. So maybe they've tried multiple different treatments and you're not like, what do I do with this person? Contingency management could be the treatment that helps make things change. So these graphs are just sort of from an old paper, but they are just pointing to kind of what we often see as the effect sizes, and significant increases in the length of time a person is retained in treatment, as well as increases in how long they're able to maintain strings of days where they're abstinent. And that's sort of the mechanism we think that might be what leads to behavioral change and reduction of methamphetamine use or stimulant use with contingency management is the patients are able to put together a string of time where they're not using, and then the natural reinforcers in their life take over. They realize they can do this. They build their self-efficacy. They're like, okay, I cannot be on this medicine, and my buprenorphine works better. My loved ones want me around. I'm not engaging in these illegal acts to procure this drug, and they are able to kind of see that their life is better after they've kind of had that like trial abstinence period. Next slide. So one of the big next slide, sorry, Bill. Yeah. One of the big criticisms of contingency management was that it didn't have a long-term outcome. So that as soon as you stopped paying people to be sober, basically, they'd go right back to using. This is a recent study that came out just at right after the first of the year, that we found that overall contingency management significantly improved outcomes above and beyond any other treatment. And this is a little bit of a busy slide. This is the forest plot of all of the studies that were included, but that way you have all the different papers the list of all the different papers we looked at, and anything where the little black square is favoring CM, all of those studies found a significant benefit of contingency management above and beyond standard care treatment, which in some cases was intensive outpatient treatment, so really high quality treatments, including cognitive behavioral therapy, 12-step facilitation, and so we're hoping that this is going to help us kind of push CM forward a bit further. Next slide. So I'm just going to go through these pretty quickly. So just some fundamental aspects of CM, if you're wanting to engage or implement this program, is that you're going to be wanting to frequently monitor a specific target, so abstinence from a stimulant, and then provide reinforcement each time that behavior is demonstrated. And then you don't give the reward if it's removed. Next slide. And unfortunately, if you're saying, oh, this is cool, this works, like, why aren't we doing this? The reason is that there's significant barriers to implementing this. The biggest one pretty much at this point is that you can't get reimbursement for insurance from it. So primarily contingency management has been happening in clinical trial type settings where we aren't able to kind of get people access to it. Next slide. We have a few ideas in place to try to help get this through, including working with up through, there's people literally lobbying the federal government right now, trying to increase access to federal funds for contingency management and allow reimbursement to be put forward. All right, and then next slide. So alternative treatment options. So this is another pretty recent review that tried to look at all the different treatment types that kind of have been tested for stimulant use disorder. And they found above and beyond also, as other reviews have found, is that contingency management is it. The only treatment that has significant positive outcomes consistently is contingency management. Cognitive behavioral therapy, which we think of as a really strong psychotherapy option, didn't have sufficient support. We also have a range of other medications. So antidepressants have been used and tested pretty widely. And the thought kind of here being that there's this downregulation of dopamine and serotonin that happens with chronic stimulant use, but it doesn't seem to decrease stimulant use, although it does improve mood. There was one small RCT with mirtazapine that did find some reduction in use. There's a little bit of evidence for psychostimulants with methylphenidate being having the best evidence for support for use. The idea being that if we have this kind of slower acting stimulant on board, that's a medication that's we know exactly what its potency is. This is kind of a harm reduction model alternative, and the patients use the stimulant instead of the stimulant for meth or cocaine. And then there was a really recent study that I think about a month ago came out that isn't on this slide because it didn't make it into this review, which they did a combination of bupropion and naltrexone. And people got really excited about this treatment option because in general, persons did significantly better on the combination compared to placebo. But when you actually pull this study and kind of dial down into it, it was a sample of about 400 participants, and it was 21 participants in the active group compared to 12 in the placebo that had a favorable response. So we're talking pretty small response rates. And I don't know if once it gets to the level where kind of multiple people have tried this combination, if things will look better or things will look worse kind of on the review level. That's why this Ronsley paper is really strong, in my opinion, is because they look overall at all of the trials and all of the reviews of all of the trials and kind of draw lines about, all right, these ones have no support really at all, like don't do this probably. And then these are some areas where we perhaps can ask some more research questions and explore further, but there could be some support. All right, I think we just start references on our next one. Thanks.
Beautiful. That was wonderful. Thank you so much, both of you, for doing that. What questions do you guys have for our two presenters?
Joyce, I have a couple of questions. One, from what I have been reading, the contingency management seems to work best in our youngest addiction patients, and not as well as they enter the older adult age group. But it seems that adolescents are particularly sensitive to contingency management treatments, not just for stimulants, but in general. They're more responsive to contingency management. Have you noticed anything in age distributions with methamphetamine for contingency management?
So this is a little tricky because a lot of these earlier studies, like that 2005 paper I posted, is methadone, and patients in methadone treatments in 2005 were generally like 50 to 60-year-olds, kind of long-term patients that had been on methadone for a long time and were continuing to be on methadone for a long time. So yes, if you have like someone that's more treatment naive, they tend to do better in anything we throw at them. But whereas these kind of more chronically relapsing or chronic returning to use patients, we just don't see as good of outcomes. So I don't know if it's cohort effects or experience effects, but yes, younger persons tend to do better in treatment. Yeah.
Well, and the other follow-on relates to our in using contingency management, you mentioned that it's generally trials that have grants that are providing funding. And specifically in I don't know if it's just Tennessee or with Medicaid, you've got a very limited amount of room for any kind of dollar value for contingency management. Are there other, besides financial, what particular areas of contingency management perks do you see as being particularly useful currently under our current regulatory status?
Like what parts of it can we do with the funding options we have? I don't know. There's not data so the lowest, they've done some of the clinical trials they've looked at and they've tried to, the original trials were about $1,200 per person was how much they were paying them in reimbursement for incentives. And with a prize-based option where people are kind of pulling slips out of a fishbowl to randomly get chances for prizes, you can get the cost of the intervention down to about $300. But the state opioid response grants have been able, patients enrolled in that, they're able to allocate up to $75 per person per year towards stimulant use treatment, which markedly lower than $300. And then, yeah, I think the Medicaid, I think if you can do $40 before you get into that kickback law messiness that I try to stay away from because I don't want to have to talk to lawyers. We don't know. We don't know if you give that low amount of an incentive, if it will work. Over Mountain Recovery, just up the street in Gray, they're starting a contingency management like program soon, which is going to be kind of like a points-based system where they're going to try to engage patients in a kind of a lot of different dimensions of recovery, lifestyle, and kind of getting it more involved in groups and building almost a recovery community where people get incentives for engagement in that community. And our hypothesis there is that if it's not just paying people to get sober that makes the methamphetamine reduction in contingency management, it's that they have kind of an accountability and that they're creating traction and little baby steps towards recovery that could be sustaining, but it's an empirical question. We don't know.
Great. Awesome. Thank you, Meredith. That was a fabulous presentation from the two of you, something very important as Bill led into when he introduced the topic to us. So thank you very much for that today. While we are switching over to our case presentation, so we'll get Veronica or Brian, whoever has the case to put up on the screen, share that for us. We've had some people join us during the presentation, so I'm going to ask them to introduce themselves. Munisa, can you unmute and introduce, please?
Nisa Khan, Family Medicine from the University of Tennessee in Memphis.
Wonderful. It's good to have you with us again, Munisa. We've missed you. Amanda, if you can unmute and introduce, please.
Hi, I'm Amanda McCurry. I'm a family nurse practitioner resident at ETSU, and I work at the Johnson City Community Health Clinic. Thanks.
Great. It's good to have you with us again, too, Amanda. Debbie, if you can unmute and introduce, please.
I guess it's morning or afternoon. I'm not sure which. My name is Debbie Hillen, and I'm with Buffalo Valley.
Wonderful. It's good to have you with us as well. We've got wonderful representation across the board today. Kelsey, if you can unmute and introduce, please.
Hey, I'm Kelsey Wallace. I'm a nurse practitioner. I'm entering a psych specific program in the summer, so happy to be here.
Wonderful. Getting a great introduction, and we hope to continue to see you after you've started the program. Thank you for joining us. Suzanne, if you can unmute and introduce, please.
Hi, I'm Suzanne Fletcher Thompson. I'm a physician with an addiction recovery center working for my son for free.
We may have a job for you then, Suzanne. You've got the right price tag. It's good to have you join us again, Suzanne. Thank you for being here.
Sure. Bye-bye.
Bye. Ryan, if you can unmute and introduce, please.
Hi, my name is Ryan Toole. I am the clinical pharmacist at ETSU Family Medicine Clinic, and I teach at the Gatton College of Pharmacy, and I am a hub team member.
Beautiful. Thank you so much, Ryan. I think I've caught up with everyone who has joined us during the presentation. If I happen to realize that I missed someone, don't worry, I'll come back around and get you to introduce again. Veronica, please tell us about your case.
Hi, and for those of you that just joined, so I'm Veronica. I'm a certified peer recovery specialist / social worker in 3 weeks here at ETSU Family Medicine. And this case, I want to preface it a little bit. This particular patient I have worked with different hats that I have worn over the past few years. So I've known her since about 2019. And the clinical question is just pretty much the overall of what we encounter with a lot of our patients, just recommendations on what a provider can do, specifically in this case of when the patient states that they are not willing to quit drinking due to the stress of their current situation. She has been in recovery for 5 years successfully on buprenorphine, but she is still battling drinking, her alcohol use disorder. So, but I'll read through this. So the past medical history is, as we know, just head injury with a car accident at age 16. That was pretty significant for her. Her psych history is a suicide attempt at the age of 17. She has a history of anxiety, depression, and PTSD due to this car accident. She still to this day cannot drive, even in her local town. She has, again, the trauma history that includes the car accident, the divorce with her parents at age 15, and a history of current abuse of a romantic partner who's just the father of her children that she's not currently with, but is currently living with. She has not attended any kind of inpatient or IOP. She was at a previous OBOT where she was stabilized on Suboxone for, like I said, the past 5 years. Strongwell, which is kind of a bridge and gap, a wraparound service she's been involved with for over a year, but only with the certified peer recovery specialist. I was her certified peer recovery specialist whenever I was there at Strongwell. She did not engage with the therapist there. Again, she has trust issues and anxiety, but with meeting with a therapist and even going to groups, so that's been a barrier. Let's see, she came to ETSU Addiction Medicine Clinic it's been a few months now, sometime last year, back in August, when some laws changed about having insurance and being in a cash pay clinic. Her substance use history, she was a previous IV user of opiates and benzos. But like I keep saying, she's in a stable recovery right now, except for the alcohol. The alcohol is what has kind of been a thorn in her side that she knows that she needs to give up, but is not willing to give up. She is currently drinking daily, and she does the whole 2 for $3.50. That's why every time I try to ask her if she can just buy one beer, she can't, because it's 2 for $3.50, 24 ounces from the gas station. But she reports that she's currently drinking these. She's splitting them up in little glasses each night, so it feels like she's having more when she's just having the same amount. Her PHQ-9 is 18. Her GAD-7 was 16, and her A score is 4. She only has a high school diploma. She has no legal issues. So she currently lives with the father of her children. They are not together, and this is the source of her anxiety, because they have been together since they were 16. They used together, but he is actually currently in the middle of very serious legal issues for carnal knowledge and to be on the sex offender registry. And she feels like she cannot leave because the house is in his mother's name, and she is currently applying for housing to try to get out of that situation. And she's honestly just waiting for him to go to jail, but because of COVID, it has been pushed off for the past 1.5 years for him to even be sentenced. She works full-time. She works a 40-hour a week. She is the sole provider of her children. He does not provide, even whenever he is at home. He doesn't watch the children. He's just there. But she does have a support system but they're in Virginia. And again, she's so anxious about driving. She will not drive to Virginia to see her grandmother. I believe both of her parents are deceased. She has a brother that was just recently released from incarceration. And there's also something there with him. He was incarcerated also because he had carnal knowledge and some minor things, or some, not minor things, but some sexual abuse allegations with a minor. And she doesn't really identify that many people as a support, except for she's blossomed well here in the ETSU clinic and connecting with people. But her mother passed away of cancer. Her father was also had alcohol use disorder and cannabis use. Her brother also struggles with stimulant use disorder, specifically right now with IV use. I'm not sure if he's returned to use since after he's been released from incarceration. Oh, wow, I have a lot. Okay, sorry. So I've just really kind of went over that entire thing about the partner and how he is the source of her stress right now, being in home, and she feels like she has no sort of help. So this is why she is kind of ambivalent on moving to another stage of change with her alcohol use disorder, because she believes this is what keeps her sane and keeps her going. But she is very honest and very kind. She's compassionate. She's a wonderful mother. She does anything for her children, and she's very responsive to any kind of treatment. She'll do what is asked of her. She's come out of her shell a lot in the past year and a half, but she is very honest with, I know, and we actually had a breakthrough a couple weeks ago. She said, I don't want my children to lose me, and I know that I'm knocking on that door because of her alcohol use. She has this, and I'm not sure of all the details, but she does have significant health issues because of her alcohol use. So any kind of recommendations on how to push her more into the right direction, because even when discussing her significant health issues, it's not much of a motivator.
Great. Thank you, Veronica, for presenting that case to us. I'm going to do a real quick synopsis of it just to kind of gel all of our brains on that. Female with history of opioid and benzo use disorder that she is in recovery for those. However, she continues to use alcohol at a rate she's not able to control, 24-ounce beers, 2 of them a night. She has past medical history of a head injury secondary to a car accident at age 16, which has turned into a PTSD type of picture and impacts to this day her ability to drive and get in the car and be where she needs to be. History of suicide attempt at 17. Her parents divorced at 15. History of intimate partner violence, and that is the person with whom she lives and is the driving source of the stress that she connects her continued use of alcohol because of that living situation. She is the sole provider for her family, works at a Kroger 40 hours a week. She's not been an inpatient, not done intensive outpatient. She has engaged with CPRS services through Strongwell, thanks to you, and has been stable on buprenorphine for 5 years from an OBOT, but had to transition her care because she has insurance, so she got moved over to us. High scores on a PHQ-9, GAD-7, and her ACEs, has a high school diploma, no legal issues, and is really just waiting on this person that she lives with, who causes great stress, to go to jail or she gets subsequent housing. So knowing the environment that she's in and that she has had some improvement, really the question you're coming to us is what else can we kind of help encourage her to move forward and to make some of those steps towards change, especially since she too is identifying her current alcohol use is not a healthy choice for her and her kids. Any clarifying questions for Veronica?
Question about any ongoing therapy for her PTSD.
As of right now, she is not doing any kind of therapy except for the groups that she attends when she comes into clinic, but no individual.
Is she engaged with any 12-step programs?
She is not, as she has anxiety of not only driving, but driving at night. And a lot of the 12-step programs is in the evenings.
Okay. I have some recommendations around that when we get to it.
Other clarifying questions for Veronica?
any, so is she on, I think you said she's managed on Suboxone, any other medications?
Probably, but I'm not aware of that. I believe Dr. Geller could actually answer that question.
And has she been on, is Suboxone the only thing she's been on for like substance use disorder?
As far as I know, yes.
Is the partner risk to the kids?
So this has been also a thorn in my side for as long as I've worked with her. The school knows that he lives there. They have deemed it safe for him to be there since it was a 17-year-old, but I'm very confused of why it's okay for him to stay there, but yes, it is okay for him to stay there.
Other clarifying questions? All right, if not, then we will get into some recommendations. I think Bill had something.
I do. So AA has pivoted very effectively over the last year online. And I'm going to drop my favorite online warehouse of meetings. This particular website, it updates every half hour, basically, and there are meetings constantly, all day long. And she can participate at whatever level. She can leave her camera off. Of course, I think engaging in some type of share is usually pretty effective. Saying things out loud. I have in the past gone with folks, just logged in with them, for the meetings. But I'm not a clinician and I'm not a practitioner. That's just sort of anecdotally some things that I've done. But as far as access to 12-step programs, it's increased dramatically with Zoom and other software.
And I think that's a beautiful recommendation. I didn't honestly think about the virtual aspect of it because I've tried to because I have the ability to meet her at meetings to go with her since I am a part of the recovery community. But I will be honest that sometimes the recovery community she is fearful of the stigma of her being on MAT and going to a 12-step program. And so that's where a lot of her anxiety comes from going to, but I've been working with her on her understanding that she doesn't have to tell everybody that. She doesn't have to tell anybody that. So
they don't need to know.
Yeah.
They don't. So
thank you for that.
Sure.
Simona.
Yeah, so Veronica, like I know you had mentioned our G87 and our PHQ-9 scores, and oftentimes like alcohol is, alcohol is a depressant itself, and patients are often drinking to cope, but I think exploring that with her, like how that can worsen her mood, it can take up to a month of sobriety to actually feel better from that. And I was just gonna say, like, using more of those motivational interviewing techniques to kind of really understand like what is alcohol doing for her. But I mean, it sounds like she's not, I think that's what you were asking, right? It's like, how do we motivate her? But yeah, I think exploring that with her, just how alcohol is contributing to that depression and anxiety.
Great, thank you, Simona. Meredith?
So the PTSD is what I kind of was flagged for me, because we have really effective psychotherapy options for PTSD that can make symptoms go away significantly. And most providers will work with them, even if they're not like as long as they're sober in the moment and can consent, they don't require that they quit drinking before they get treatment for PTSD. And often you'll see this happen with the veterans I've worked with, that you treat the PTSD and those hyperarousal symptoms, that numbing that they're using the alcohol for, like they don't have any of those symptoms anymore, or they're so much more manageable that the alcohol use can kind of naturally fall off. And then another thought is I don't know if she's connected, there's the Family Justice Center in Johnson City, which has, they offer free PTSD psychotherapy for persons that are survivors of domestic violence relationships, but they also maybe would know something about how to get them out of that house, like orders of protection for the kids or something. I don't know, because that
I'm
just
so glad you said that, because I know they have a rapid rehousing program, and I don't know why that's never dawned on me. So
yeah, every time I've made referrals over there, the feedback I've gotten is that they have really wraparound, comprehensive, and are very, very helpful, and are like maybe perhaps over-resourced at the moment for how little people have been knowing that they're there. So that's good for people that show up there. But I don't know. I know nothing about those laws, but that sucks that he's in that house.
oh yes, we've addressed it many times, and it just it's uncanny how it just continues to get pushed under the rug because of COVID, especially how people aren't coming out to do anything, or especially the court systems, and it just keeps getting pushed out and pushed out. And I think at this point, he might not even be going to jail, and it's some pretty significant charges he had. So, but I like the Family Justice Center idea.
Yeah, because the orders of protection in Tennessee, like they can make it so that he has, like, even if it's his house, he'd have to leave the house for however long it's for. So.
Great. Thank you, Meredith.
I'm sorry.
No, go ahead.
If in fact she is willing and is motivated to quit, something else I have seen used, don't have a ton of experience doing myself, but some of the other clinicians could probably pitch in, would be a Camprosate or Camprol. I know she's not a great naltrexone candidate, but that could be if she likes taking Suboxone or likes taking a medicine every day to help with that. I know that has pretty good evidence.
I know with our MAT patients that I work with really closely, we do a lot of oral naltrexone with Antabuse, and we do the shot. Right now we have a patient that is doing the Vivitrol shot, and he takes Antabuse with the shot, and we've done it for about 6 months, and he's done wonderful. But my main concern for her, she is so in denial. There is a lot of denial going on. She is not ready to change, and you have to meet her where she's at. And if we look at the stages of change, she's very ambivalent right now. She's aware that there's a problem, but she doesn't want to mentally work on it. She's physically going through things, but we have to teach her how to feel and think. This is a whole problem with people in addiction. They don't want to feel and think, so they drink or they use substance to not feel and think, because they're two different things. And to teach her to feel, think, and communicate first, then behave on it. Because right now she's behaving, then she's telling you what you want to hear. Because when she drinks, that's her liquid courage, is her to drink the substances, for her to have liquid courage to not deal with anything. And my concern for her, she needs individual right now. I think the groups are a trigger, because if people come in affected, that's going to trigger her even more. She can smell things, she can sense things. But working in alcohol, it's a depressant. She's not, what I gather from you, Veronica, she's not on any antidepressant medication or anything. So we need to screen her more for what depression is going on and how her alcohol is increasing the PTSD, because her addiction is increasing everything with her mental health. So my recommendation would be to do more individual, kind of meet her where she's at and kind of understand. I know that there's a lot of situational factors that she can't change, but what emotional strain does she have that she's attached to the alcohol?
Thank you.
Yes, thank you, Brooke. There was Kelsey. Yes, you just shared something with us. Can you talk a little bit about that, the Branch House?
Sure. I shared the link for Branch House. They're a family justice center. I believe they cover Sullivan because Washington has one as well. And I think their coordinator is Daniel Austiner, but Lene and Brittany Fleener at Branch House are amazing. They do the orders of protection. I know we work pretty closely with them on I'm on a grant about sexual assault response in the area, a HRSA grant. So we work really closely with them. And I know that they are one of those agencies that will do whatever it takes to meet patients wherever they need to be met. You know, so they'll meet, you know, I know there's one situation where somebody's husband, they're not allowed to use a car, but they can go one certain place, one certain time a week, and advocacy comes out and meets them there. So they're flexible and a great team that's really committed to helping the community. So I just wanted to link them because I know I can vouch for them personally. They will help.
Beautiful. Having that resource is great, and the one that you sent to Bill in the chat. So I know everybody's little chat bubbles pop up. I don't know if there's a way to disable it. Maybe some of you guys know that. So if you have disabled your chat popping up, look at it now, because Bill shared the AA information and Kelsey's got the information for the Branch House as well. So you want to grab those resources. You know, I'm going to grab those resources when we're done with our ECHO, because they're great resources, and you guys are sharing some really awesome ideas and insight. There's nothing like, you know, hanging out in the middle of our forest and you know, forgetting that there were some trees over there. The comments about the alcohol being a depressant, the PTSD piece, there's a lot of elements there that, like, yeah, we know this is great. You guys are reinforcing that for us. It's really good information, these suggestions, getting our wheels going again, because I know you've all experienced this too when you're working with patients and you're working really hard and they're working really hard. Sometimes it's good just to share what you're seeing and experiencing. I'm hoping some of these ideas are helping you all when you're thinking about your patients as well. Because I know I share in the care of this patient too, and I'm like, yeah, these are great ideas. Acamprosate, lovely suggestion, Jack. Thank you. Any other suggestions from anyone?
I just have a comment. And in the past, we've had a lot of discussion about cases, and I always wondered, gee, I thought a peer recovery specialist would be great to help with the recovery. So I am so pleased and appreciative of Veronica's efforts here, and that you have this as a resource right at ETSU.
Yes, no, it's fabulous having Veronica here with us. It is like I got Christmas every day I come to work. It is. But you know, I can speak from this perspective of our team. I know I'm your facilitator first here on ECHO, but there's a lot of my team members who are on this call. So when I say, like, I'm so impressed with the great work that you do, it's like, yeah, because I get to help out with that and I'm part of that great team. It makes me very happy to be on this team of really engaged and caring individuals. It's great to have all of you guys as part of our team as well, and joining our ECHO every 2 weeks and contributing your thoughts and ideas. Having a community like this that cares so much about taking good care about the patients and the individuals we encounter. You guys have had some great ideas. Any other suggestions for this case? Yes, Cameron.
Well, I just want to mention this one. Sometimes the patient doesn't want to, you know, face the problem that they have, and they know that this is a problem because they don't know if there is any alternative to it. So right now, I mean, a few days ago, I was talking to a patient that is an end stage, you know, lung disease, and he's a smoker. And I was told that if you bring up that the smoking cessation, he will cut you off. And he did. As soon as I talk about it, he says, let me stop you, doc. I'm not going to quit the smoking. And I said, I don't want you to quit. I just want to let you know that if you want, you know, just reduce your smoking a cigarette, we have the gum that you can, you know, have a nicotine, and that will reduce your craving. Therefore, you don't have to smoke a pack a day. So that harm reduction, you know, stage, and he accepted that. I mean, as soon as I said that, he accepted that. Now, in this case, especially with the recommendation of the acamprosate, for example, to reduce the craving, it may help for her to reduce the amount of the, instead of the one, I mean, I know that she has to buy the, you know, 24 ounces because it's cheaper, but instead of the, you know, drinking both of them in one night, she may go with one bottle of the 24. And gradually reduce the numbers of the things. And that would be a saving process for her too. Seems like that she's working hard She's keeping up with that 40 hours, work every week. And those are the, very important thing for her. And she's limiting her drinking to the night in order to, be able to work during the day. So those are the things that from the perspective of the treatment of the alcohol use, all the things that was said, it's true. And we need to have a motivation and all those stuff. But that is also very important to give the alternative.
Thank you so much, Cameron, for encapsulating all of that for us with your recommendations back. It is that time again. We had the 12:15 start time. We've hit our 1:15 stop time. It was great seeing everyone. We will see you again on the 28th. Veronica gave us a great case. Don't you want to be like Veronica and give us a great case in 2 weeks? So reach out to us. Melissa is the one you want to get a hold of. You can get a hold of any of us as well on the hub team. Let us know that you want to submit a case. We'll help walk you through that. Or you can just go straight to our website and find the place where you can submit the case, click it, open it, fill it out, send it in. And we'll be talking to you about your case in 2 weeks. Thank you, everyone. Take care.